joining us once again, Professor Egede.
Glad to be here.
Now, people who have listened to your first interview will know that a lot of your research touches on aspects of race in science and society and kind of the social well-being aspects. Could you give us a bit of an introduction to what we're talking through today?
Yeah, so I think the last time we talked about some of the social determinants of health, structural inequalities, and then structural determinants of health. And so today we're transitioning to the whole concept of behavioral economics and how financial incentives can be used to actually motivate behavior change in populations where behavior change is really difficult to achieve.
hmm Yeah, the threads between income and well-being and function in society and equality seem to be very tangled from what I've read of your work and what I can see of the world at large. So, if we could start pulling on some of those to see where the pieces come together, could you tell me about maybe some of the existing literature? What does the world look like at the moment in terms of how financial incentives and health interventions are related?
Yeah, so it's very clear that income and wealth, though they're different, mean different things, but actually are connected. So income is really more about how much you make year to year, whereas wealth is historical information you actually have. And so combined, it's very clear that those who are wealthier tend to have better health outcomes. That's because they have access to resources, they have access to the best healthcare possible. They tend to have better built environment, housing, transportation. And so, what we are then asking the question, since we know that these differences exist, there's the whole concept of how do you then leverage income and wealth to actually improve health and health outcomes. One way to think about that is that if you had all the resources in the world, you could just change people's financial situation and just give them money. And so there are three areas or three ways that this wealth and income issue is being focused on. One is the whole idea of the concept of income supplementation. So income supplementation essentially says someone has a base level of income and then you can lift them up by giving a little bit extra to move them to some kind of minimum livable wage. So an amount of income that will allow them have a meaningful existence, and this will vary from country to country. So that's income supplementation. Income supplementation is a little bit different from universal basic income. Universal basic income is essentially where you say, we're actually going to give you money to essentially stabilize people across the board. And so with income supplementation, the amount that's given is usually limited. In the US, it's roughly about between $300 and $500 just to help supplement living expenses. Whereas universal basic income is essentially saying, we're going to lift you to a certain threshold, and the amounts that are spent in that is typically in the thousands of range to actually move people up. And then the third area that is kind of tangled in that whole conversation is the whole issue of incentives. The difference between universal basic income and incentives is that financial incentives have nothing to do with your base income. It's really about motivation for behavior.
Mhm.
So whether you're rich or poor, everyone responds to financial incentives. When we use the word income supplementation, we're talking about people who are limited resources, universal basic income, people who have limited resources. But with incentives, it applies to everyone and it's just one of the tools available to change behavior. So the idea with incentives is that we have something called intrinsic and extrinsic motivation. Intrinsic motivation is what happens when you have decided you've owned the behavior and you are changing behavior because of your internal motivation. Whereas extrinsic are the things outside of you that may help you nudge you towards behavior. Financial incentives are one of those extrinsic motivators. They nudge you towards behavior because they essentially get you to start something, and hopefully you can then transition from an extrinsic to intrinsic motivation.
And when we look at the US as kind of a geographical sense of where these things might work and for what kind of people in those locations this might work for, how does the existing barriers in terms of wealth disparity reflect for who is best placed to receive those incentives?
Yeah. So I think what we try to clarify is that, so if you look at the US statistics from the census statistics, the median household wealth of the non-Hispanic white population is roughly about 188,000, whereas for Black households, it's roughly about 14,000, and for Hispanic households, roughly about 32,000. So there's huge disparity on average. Obviously, there are rich Black people, there are rich Hispanic people, but on average, for population level, white households actually have more income than Black households. So if you're thinking about the concept of who will benefit from income supplementation, and maybe universal basic income is obviously households that are relatively poorer. So we would actually say it is not so much because there are white households that are also poor. A lot of these programs are designed for people who live below a certain income level, regardless of your race or your ethnicity.
And to tie this into what we covered in the previous episode with diabetes in your research as a particular example, could you tell me where does diabetes fit in terms of the US health economic landscape?
Yeah. So diabetes is also a disease that is two things. It's actually tied to poverty because most of the dietary requirements, healthy food costs money. Diabetes is also very expensive. And so in terms of cost of taking care of buying medications, buying supplies, but then also neighborhoods. So the ability to have a place where you can walk around, you can actually exercise is also tied to income. So people who are lower income tend to live in concentrated poverty, tend to live in neighborhoods that are not safe. So they can't exercise, they can't walk around, and they probably don't have grocery stores that are readily available. So healthy foods are not an option. So income has a huge impact to play on diabetes and diabetes outcomes. And individuals who are in lower income segments tend to have a disadvantage at multiple levels, including, like I said, access to care, being able to afford insurance, being able to have good doctors, good treatments, access to healthy foods, access to housing, access to safe neighborhoods, all of those factors, which are all detrimental to diabetes outcomes.
Mhm. And in terms of the burden, in a previous episode, we mentioned that diabetes affects 13% of the US population generally. What does that look like in dollar values?
Yeah, so I think as you look at the economic, I'm just going to reference kind of there's a recent paper that just came out that looked at the cost of diabetes in 2022. And so that is called Economic Cost of Diabetes in 2022. This is published so often by the In Diabetes Care, and it summarizes data and looks at cost of diabetes. And when you look at overall cost of diabetes in 2022, in the US, it costs about $412 billion. Of that, about 306 billion is direct medical cost and 106 billion is indirect cost. It then shows that for people diagnosed with diabetes, about 1 in 4 healthcare dollars in the US is tied to diabetes. And about 61% of that cost is attributable to diabetes. So diabetes has a huge impact on cost. And then when you look at the annual expenditure for individuals with diabetes incur medical expenditures of roughly about 20,000 per year. And then approximately 12,000 of that alone is due to diabetes. And then when you look at medical expenditures, individuals with diabetes have on average about almost 3 times higher cost compared to individuals without diabetes. So again, you see that diabetes is a huge driver of cost of healthcare. But the other part of it is because of the disability that's due to diabetes, you have reduced employment due to diabetes, you have lost productivity or premature deaths. And so roughly about 32 billion of that total cost is due to lost productivity. People can't work, they can't get to work because of the underlying diabetes.
Mm. That touches on my next question of insulin costs being something that have been discussed as a kind of a major problem for the diabetic population in terms of a healthcare cost burden. What kind of percentage of that burden is made up just in terms of a preventative medicine like insulin? If there's any kind of data that can say, here is the monthly cost of insulin, here is how that looks as an annual sum.
Yeah, so I think when you look at the cost of, in terms of millions of dollars or in terms of average cost, so insulin is actually one of the most expensive medications that we actually have because it's very effective. A lot of individuals use it. We obviously have newer medications now that cost just as much, right? And so when you look at the data from roughly the 2022 estimates, the average cost of insulin is roughly about $22,000 a year for people to actually pay for insulin. So that's a lot of cost. And when you look at the total cost in terms of the average cost per individual, insulin alone accounts for about $22,000 of average cost for the individual. So for those who are on insulin. And then when you look at in terms of medications, again, you're looking at roughly just medications alone is roughly about $631 million. That gives you a sense of how much money medications actually cost for diabetes. And that's why if you don't have insurance or you're not able to afford this, I mean, that's just huge, huge cost.
Mm. I mean, there's the ongoing discussion and shifting policy around the price cap on insulin, and we can skip if it's something that's not necessarily reflected in your research of, do you see that as being something that is having any impact on the cost and health burdens?
Absolutely. I think, I mean, obviously, this is just being introduced. There was legislation that was introduced, and many of the pharmaceutical companies are now on board with trying to set a reasonable price for insulin. I think that's going to have a major impact, especially for lower income individuals or those who are not insured, because the cost, even those who have insurance, the co-pays, which is
Mm.
the extra money you pay out of pocket, by lowering the cost, that will actually help those individuals be able to afford medications.
Because without that cap and without that assistance, I mean, is there an income threshold? Is there an annual salary per year at which diabetes moves from being a condition that you can live with to a health concern? Because, I mean, I've seen anecdotes of people dying due to diabetic complications because they've been trying to ration their insulin because they cannot keep up with payments, that sort of thing.
Yeah. Oh, I think regardless of your income level, diabetes is expensive.
Mm,
And it's a function of, so there are multiple factors that come into play, whether you have complications, how many hospital stays you have. So if you have to spend your time in the hospital, your cost increases exponentially. It
mm.
goes from just the average cost we described to huge expenses. If you have insurance, versus not having insurance. That makes a huge difference. Then depends on how severe your disease is. So if you're early on in the disease versus later on in the disease, more complications. So I think across the board, diabetes is expensive regardless of the income level, but below a certain income level, like you're describing, it literally becomes a survival issue. 70% of bankruptcies are due to health related costs where people can pay their costs. So you can imagine if you're below the median income level, so if you're making less than 50,000 a year and you have diabetes, it's going to be very, very challenging pay for your care to cover the test strips, the things that are needed for managing diabetes, and it makes it really difficult.
I mean, money does outsource a lot of the problems that come with it, but is there any assurance that people can have from, I mean, we're going to get into some of the financial incentive trials going forwards, but to kind of reflect on what we've covered so far, what do maybe policymakers need to know about how expensive it is to be poor? And then we can get onto the financial incentive trials as, here are suggested fixes, here are suggested solutions.
Yeah, one of the things we don't do a very good job at on the research and clinical side is we actually don't distill information so that policymakers can have a better sense of what it means. You know, in most policy for individuals, legislators are not going to read a full-fledged paper. They're unlikely to sit down. Maybe they have their legislative staff review it. And so the more we're able to use visuals, things like graphic abstracts, where people can quick snapshot, get information, I think that's going to help. But more importantly, I think being able to create data that summarizes costs in a way, so what I just did was I pulled data from a large publication, right? The ability to actually digest that information and say to people, here's what we're really talking about. Here's what an average individual with diabetes costs about 22,000 versus someone who doesn't have diabetes. And that type of information is going to actually help policymakers. But I also think that if there's one message, the message is that diabetes is expensive. It's highly prevalent, it's expensive. And the more we're able to increase access to healthcare, access to health insurance, that is going to actually go a long way to covering the cost of diabetes.
Well, as a clinical trial in terms of public health initiatives, and I mean, it feels weird to use money as a medication effectively. Could you talk me through some of the trials that have been put in place for financial incentives? What has been previously deployed? What shows promise? And if there's anything that is working particularly well? We've got the.
I will walk backwards and talk about, because, like I said, there are three areas we are studying right now.
Mhm,
One is universal basic income, two is income supplementation, and the
mhm,
third is actually incentives. So the two that are very critical, because those are where a lot of the policy issues are going to drive, are universal basic income and income supplementation. Because incentives, people can get incentives. So let me just talk about each of those studies that we've actually done. The
please.
first one is universal basic income. We have a member of our team where we are actually saying if we took people who are low income with diabetes, who are living below the poverty line with diabetes, and we actually gave them a monthly income of $500. And that $500 is ideally designed to offset a lot of the cost of the things they have to deal with. In the context of those funds, there's something called conditional and unconditional.
Mhm.
Conditional means that it's conditional on them doing something. In this case, we're asking them to attend every 2 weeks, attend the diabetes education session. At the end of the month, if they attend those sessions, they get the $500. Whereas unconditional is that they get the money regardless of whatever they do, and our goal is to see whether making it conditional versus unconditional will have an impact
Mhm.
on diabetes outcomes. The goal is to recruit 100 individuals, 50 and 50 in each group. We're going to test this over a period of time to see if it makes a difference. We've actually completed recruitment for that study, and we're now in the follow-up phase. But a couple of things we've actually observed. One of the challenges or criticisms of basic income is the idea that if you give people money, they may use it for drugs, they may use it for things that are not meant to use it for. We have looked at data from that study so far. 97% of individuals in the study use the funds for things like rent, transportation, food. So
Mm.
it's being used for what it was designed to be used. And the other 3%, we don't have enough clarity to know what it was used for. But we have not seen any situation where it was just being used for illegal substances or drugs. So that's the key part. And then the participation has been virtually almost 100%. We actually had more slots. We have more people looking for slots than the slots we actually have available to give them. So there's obviously very strong interest. Now, we've not analyzed the data yet. We're going to be doing that shortly to actually look at in the next year or so to look at what does this really do. Because the next step now is to take that to a larger study to now look at low, because this current study is 6 months.
Mhm.
Our goal is to eventually demonstrate that this works and then test it in a larger sample for a 12-month period. And then we can then begin to make recommendations about how to use universal basic income.
Right. And with the people that have signed up to participate so far, how much consideration is given to the ethnic component in that?
Yeah, so this particular study right now is focused on minority groups. And so we're really focused on minority groups because we wanted to go to the highest risk group. But we intend after the this initial pilot phase to actually open it up to all groups, regardless of race, but more focused on their income level and see if we're going to get the same results.
When it comes to the reporting of that, you've mentioned that you've gathered data for both groups, the adherent and the kind of non-monitored. How are people participating in giving that information in if they have to turn up in person? Because I imagine that the pandemic had a lot of influence on how willing people were to go to hospitals, to go to medical facilities.
So we have used a combination of in-person and virtual. Yeah, we find some things are we. So, for example, the educational component, we actually do virtual for most of our studies. We have either for telephone or some form of video conferencing. We found that then the other option we actually use is going to people's homes because many times transportation coming in is actually challenging. So we actually go to them. And we found that that is actually very helpful in terms of engagement, especially for minority populations, for low income populations. It actually eases the burden of trying to get to us when we actually go to them. But in some situations, for things like the blood draws, for things like the survey administration, we actually will have people come to us. So we do a mix of virtual, in person, and then we go to their homes or they come to us. And that's kind of what we've used. Obviously, there's very strong evidence that remote areas, hard to reach areas, using telehealth makes a huge difference. So that's a whole different conversation. But what I want to also do and make sure we don't miss out is the other two studies that cover the spectrum of income. We just talked about one, which is the universal basic income. The second is the study we're doing on income supplementation. So in this case, we're taking food insecure individuals. We're randomizing 150 individuals who are food insecure, who have type 2 diabetes, and we're assigning them to three different groups of 50 each. One group gets education, they get diabetes education, and that's all they're getting. The second group gets diabetes education, but they also get income supplementation. We supplement their income by $100 every month to help them offset cost of food and things like that. And then the third group gets the income supplementation education, but they also get additional incentives if they buy healthy food. So they get a certain amount of money every month if they actually show receipts. And they can fax the receipt, so they can scan it, they can email it. And if they demonstrate they've actually bought healthy food, they get income. Again, that study, we've actually completed randomization, so we've actually recruited everyone. It's a 6-month follow-up, and so far the feedback, we haven't analyzed the data yet, but the feedback we've gotten from participants is very, very helpful. It's really helping them navigate some of the financial challenges they're facing, and we're very optimistic that if this works out well, then we can actually do a bigger study to actually then test what are the optimal ranges of income. No, I think the only thing I want to add is the concept of so I talked about 3 different financial incentive programs. We talked about universal basic income. We talked about income supplementation. The one study I didn't cover is the one on the actual incentives. And that's a study that we actually did where we took 60 individuals. We actually assigned them to 3 different incentive structures. The first incentive structure was those they were given $300 at the end of 3 months if they just took care of their diabetes. The second group got half of that incentive, 150 if they attended diabetes education classes, and the other half, 150 if they actually got their A1C or their diabetes controlled at 3 months. And then the third group got a third of the amount for attending classes, a third for monitoring their glucose at home and uploading the readings and getting good results, and then the third for lowering their achieving diabetes control. And what we found was in those 3 arms, we saw a significant drop in diabetes control or improvement in diabetes control. We use hemoglobin A1C as our measure. In all my research to date, if we get a 1% drop in A1C, we are excited. Many of the drug trials will drop A1Cs by 1.5 points. We found between a 1.7 drop to almost a 2-fold drop in A1, 2-point drop. So 1.7 to 2 points, so the very significant drop. So we use that to then get a federal grant right now that's almost wrapping up, where we're actually randomizing 450 individuals to this intervention across racial groups. And the goal is to, one, when you now expand to 18 months, so we're doing 12 months. At 12 months, we stop the incentives, and we then follow them for 6 additional months to see if stopping the incentive, at 12 months, do they get better? Then at 6 months after that, if you stop the incentives, will people move from extrinsic motivation that's all financial to intrinsic, which is based on their own internal work? But we also separated them into 3 racial groups: non-Hispanic whites, Hispanic, and then African Americans. And the goal is to see whether the incentives work differently for different racial groups. And so that study, we're done with recruitment right now. We're in that follow-up phase. We should start analyzing results by the end of this year. We'll have some initial results to see will this make a huge difference, because that's going to be a game changer in terms of how we leverage incentives.
So the question then, you mentioned the expansion hopefully coming down the line,
Yeah.
would be what would the timeline look like in an ideal world to get from these initial studies, these pilot investigations, to that larger study, to then what, city, state,
Yeah.
nationwide?
Yeah. So usually we're trying to accelerate these grants and these processes. So we actually have a pending grant that will allow us to do this in a larger sample. We're going to go to a larger sample for 12 months. And so ideally, 3 years out, we should have enough data to suggest that this is something that we can actually then pitch to policymakers, to Medicare, Medicaid, and funders to say, look, this is a viable option. Because the issue is not, it's always the question of, will this work? And then after you show that it works, then will it work for different populations? Who is going to benefit from it? We want to have enough data to actually demonstrate that for different groups, this actually works well.
I mean, without necessarily wanting to get into a political discussion about this, just going to say what I've written in the outline here. Are financial incentives a success story, or are they just catching up to where other countries have universal healthcare by other means?
I would say that let's just address the politics. I think there's a lot of conversation about that politicizes health and health, which is one of I've said this over and over again, that health is not about politics, it's about lives and people and the importance of making sure that everyone has a chance to have a healthy life. I think the incentives is not a politics conversation. It's about rational evidence. The evidence suggests that if you give people incentives, they did better. If they did better, healthcare costs less, the inpatient stays are lower, mortality rates go down. If that is true, then it is not a politics conversation, it's a rational healthcare business decision.
Mhm.
And so the way I tend to look at this, and I really want us to begin to think about this, is not to spend a lot of time thinking about the politics, because politics is subjective. People feel certain ways. But I think we are trying to generate evidence to change policy, to actually say, if you did this, this is how much it will cost you to deliver this intervention. This is how much benefit you're going to get. And if you do the cost benefit analysis, you're going to find that giving incentives is actually beneficial and it actually costs less. If that is the case, then the rational, logical thing to do is to give incentives.
It would be nice to believe that rational, sensible policy and rational, sensible business was behind a lot of the policy that is affecting public health, at least in the UK. Fingers crossed that that kind of evidence and impact does come together. So, as a kind of summary to wrap up everything that we've covered so far, we've mentioned the policymaker takeaway, but for the kind of the peer and patient, people listening to this who will be wanting to know, what can I ask my doctor or what can I ask my healthcare provider as, something to help my diabetes costs or to help my patients who are reporting that they can't make it into the clinic because they are unwell, so they can't come get their shots. Is there anything that people can take away from what we're talking about to say that change is coming, that there might be trials opening near them soon?
Yes, absolutely. I think at the patient level, at the individual level, I think we are very optimistic that one, there's a more openness to these types of studies. There's more funding coming in for these types of studies, and there are going to be more trials
Mhm.
available for participants. And most patients now, you can go to clinicaltrials.gov in the US. You can actually identify studies that are actually open and recruiting your neighborhood, and being able to actually identify those studies and being involved, I think helps generate that body of evidence. But then also, as patients, you are taxpayers, you have a right to lobby. We can lobby because we do research, right? But individuals who have access to the evidence can actually talk to their legislators and say, are you willing to entertain this idea? Are you willing to support these types of programs, and ensuring that we're not asking for people to do things, we're actually asking to follow the evidence
Mhm.
and let the evidence actually be used in a way that is objective. So that's where the individual can come in. Now, for physicians, obviously, physicians have a role to play. And one of the things as physicians and healthcare providers is to check your biases. I think there are many people who have a fundamental bias against incentives. The idea is, why should we give money to people to change behavior? They should change behavior. And the fact is, the psychological evidence, the wealth of evidence suggests that incentives drive behavior change. We've seen it for smoking cessation, we've seen it for weight loss. So there's no reason why it wouldn't work for diabetes. And evidence suggests right now that it works for diabetes. So I think for the healthcare providers, it's one, to check their bias and be open to the possibility of this being a new way of maximizing care and ensuring that patients get good outcomes. And then finally, for the insurers, again, being open to the evidence. We spend a lot of time as in the healthcare system telling people what to do, and we should be more open to things that actually are different from what you've always done, and maybe new ways of approaching the same problem, new ways of investing resources and leveraging those resources in a way that maximizes optimal health.
And if anyone listening to this wants to find more from either your papers and publications or more from your research, is there anything that we can send to them to say that this is the Egede site, come here to read your work?
Yeah, so I think what we can actually do is we're going to have a compilation of the different papers so that people can actually have a link where they can actually go to and identify those papers. They're usually all available, publicly available on the NIH sites, but we can actually provide the link so people can go look for those studies.
Professor Egede, thank you again so much for your time, and I look forward to speaking with you again soon.
All right, thank you so much. Have a good rest of the day.
And you.